screen. Thanks everyone for joining us today. We want to make this as interactive as possible. So to get started, if your agency has Handtevy already and you already have it on your phone, great. If you don't have it on your phone yet, we want you to go ahead and download it and participate with us today. So you can go to your favorite app store, whether that's Apple or Android device, download Handtevy. You'll know it's Handtevy by the little hand and the little blue icon. Once you do that, you're going to enter your registration information for yourself. And then then once you click next, it's going to ask you for username and password. Some of the information has to be like employee ID and stuff. You can skip whatever's not required during that registration process though, so that you can just get into the app. And then the code is going to be demo UT41. And I'm going to leave this here for a second. And I think there's a chat feature. Would Tia or Brianda, one of you want to chat that to everyone too? Just the demo UT41. It's the same username and password. And we'll put it in the chat too. I'll leave it up here for a second, but hopefully we can get it in the chat. And then if we move on and you haven't got there yet, we'll make it happen. But like Tia said, Handtevy has been something that we have been working on for a while. We were actually approached about it several years ago from some agencies in the state that wanted to use it and wanted to be able to utilize the training component along with it. And so we've been working pretty closely with Handtevy over the last couple of years. And then, like Tia said, when everyone wanted us to try to see if we can do this statewide, it was a project that we undertook for sure. And so,
hey Brett,
yeah,
they're getting an error message that says user inactive.
I just saw that too. Let's see. I don't know. I'm gonna pause sharing my screen really fast and see if I can fix that. This isn't gonna work. It's not gonna work. Here, let's see.
Some are saying that it is working for them. So maybe those who have gotten the user inactive, try to enter again.
Oh, I know what's happening. If they're saying user inactive, that means that they have had it before, and I took everyone off to make sure we had plenty of space today. How am I going to mitigate that problem? Let's see. While we go through this for a minute, if people want to chat their names, I can try to unlock it for you. If I can find the chat, sorry. Okay, let me see.
Do you need email addresses or just
no,
names?
I should just be able to get it. If they register with their names, I should be okay to.
Okay, so we have Ainsley Stoneman, Amber Terry, Justin Larson, Rebecca Effington.
It's forcing me to know the alphabet.
Chris Shields, Jenna Denlinger. We want to make sure that you guys can get on this demo, because it's really when the magic happens is when you actually have this in your hands and you see what this thing can do.
So Rebecca, I'm not seeing you on the list to reactivate.
I'm getting some that say it works.
Yeah.
Charlotte Lottie.
Ainsley, Amber, Justin, you guys are good.
Claire Provost.
Let's see.
Jessica Dieters. It's so fun to see these names that I read the certificates for. I love it.
some of you people that are getting it, just use a different email address, and it doesn't even have to be a real one if you're getting the user. And because like Chris, I'm not seeing you on here either.
I've got a question. Can anyone
Jen,
use
I
the
got
app
you.
even in southern Utah? I mean, southern Idaho. We are only providing the app for Utah EMS agencies, but if you want to explore this app today with our demo code, then yes, you can. Just go ahead and sign on.
Charlotte, I'm not seeing you on the list either. Just try a different email address. Like I said, it doesn't have to be real. You can just put something
Make
in.
up your own email addresses, guys.
Or a
Most
different one. If you have a
will get a
personal one or a
prize.
work one, use the opposite just so that it can. Claire, same for you. I don't see you on here either.
Maybe it's because so many people are signing on at once.
Some of them I'm checking for sure. Okay, I think everyone that's in the chat, if you were on here, I think I've done it. If you still are having problems, just try a different email address. Yeah. Oh, so if it's saying what it is, you can, if it says demo and you're trying to get in and it says that user's inactive, let me show my screen again really fast and I can. Okay, so on my screen, you can do this little ad up here in the corner and then enter that information again there and it should work. For somebody that said that the username and password of the app are both demo UT41. And I'm going to try not to use it so that we save some of the seats on there, but I think we should be okay.
One interesting thing while we're waiting, the agencies that are already using this are Salt Lake Fire, Lehigh, Juab, Panguitch, Elk Ridge Fire, Saratoga Springs, and Mapleton. And every one of them has given us fantastic positive feedback.
Okay, let me do this again. So as we get in through there, hopefully there's 27 of you so far that have been able to successfully log in there. So hopefully the rest of you are getting there. If you have it for your agency, feel free to use your agency one. You don't need to use the demo codes. Try adding it again. But looks like people are getting in. So just keep trying with a different email address when you register it.
Good. Some of the folks that were not able to get in are getting in now. So I think we're good to go ahead.
All right. So we talked about what is Handtevy. Handtevy is a pediatric resuscitation system that originally revolved around the cardiac arrest, but has evolved into much of other things. It is an app-based application to reduce those medication errors. And it also is helpful for documentation purposes. And we're going to talk about the integrations as we go. So why is this important? One of the things that sometimes you need in life is a disruptor, and you can't keep doing the same thing over and over again, expecting a different result, right? And so when we look at pediatric cardiac arrest in the hospital since 1980, we've seen a pretty good uptick in the in-hospital conversion rate to saves, and versus the pre-hospital, which has been pretty flatline and the same since the 80s. So we got to do something different. Hopefully this is the different, at least a piece of the different. We know that all medications require math. You can only start after a measurement. So if you have a length-based tape, such as the original Broslow system, you'd get there, you'd lay it down next to them, and then you'd start reading it. The documentation was poor, and then the inherent stress of pediatrics. So when I talk about poor documentation, I know none of you on this call would ever do this because you all are amazing providers, but like for myself, when you come back from a cardiac arrest, sometimes you wrote things on gloves, you wrote on a piece of paper that got too sweaty in your pocket, or you threw a glove away, or whatever the times that you were working on. And so you get back to the station and you think, okay, I got on. So then you start trying to remember when you did certain things based on the time. So I got on scene at this time, probably started an IV here, gave my first dose of epi here, and kind of made up your times as you went. This tool allows for some more real-time documentation of that, and hopefully we can mitigate some of that. So why is this important? Why is this necessary? What makes this the disruptor? So part of the Handtevy idea is this Thinking Fast and Slow. It was a book by Daniel Hardman, I think is his name, and I bought it. It's kind of thick. I was going to put it on my like reading list, but it's actually a pretty big book, so it's been moved down on my reading list. But I'm going to read it. I promise I'm going to. But basically, they come with this system 1, system 2. System 1, all the things are automatic to us. System 2 are the things that make it difficult. One of those things that is difficult is math. So if I ask everybody right now, 1 + 1, don't give me the answer. Everyone automatically in your head said 1 + 1 = 2. Nobody thought, oh, I'm going to stop and not answer this question. But if I asked you, what's 24 times 13? It's going to be a little bit different. You're not going to immediately get that answer. Some of you might think about it for a second. Some of you didn't even try. And so, that system 1, system 2 is definitely plays a factor in this. And we're hoping to get everything over to that system 1, which is everything else that we do that's automatic. Does age versus length matter? And so there was a study that was put out in the American Journal of Emergency Medicine that talked about using the Handtevy method to determine weight based on age versus weight based on length. And the study basically concluded that they were identical. So when you look at the kids and what their weight was versus what their actual weight was, you can see that between the Broslow and the Handtevy age-based system, they're virtually identical. If you look at the one that the picture that's on the left here, the reason why that one is more filled in for the Handtevy versus the Broslow is that Handtevy uses every age 4, 5, 6, 7, 8, but whereas like on the blue section of the length-based tape, all of the medications are dosed the same for that 18, 20, 22 kilo kid based on their length versus specific for their age. But on the surface, though, there are no differences from using age versus length. It is appropriate to use length in a kid that you think is dramatically taller or somebody that is undersized, but by and large, the age is just as good as getting their length. Okay. So we look at, the next study that we're going to look at is does this work, like Tia said. So this is a study that came out of Polk, Florida. This study looked at Handtevy when they implemented Handtevy versus some of the other stuff. And so in 2012, 2013, this says they had 2 cardiac arrests. They got ROSC on 2 cardiac arrests out of 38 in that year. None of them survived. Then 2014, 2015, they implemented the Handtevy system. They were able to get, out of the 56 total cardiac arrests, they got ROSC on 17 and 13 of them survived intact, which means they were discharged from the hospital neurologically intact. It does include some deficits, but they had to, by and large, be neurologically intact. And then the next thing that they looked at was reducing the time to epi. So the study that's out there that talks about that the epi may not work as well in cardiac arrest, the 8,000 people, the 4,000 or the placebo group, 4,000 that got epi, that mean time to epi was like 21 minutes. And so this looked at putting epi in the first 5 minutes of cardiac arrest, increased their survival rate even more. So now of the 49 cardiac arrests they got 17 that survived neurologically intact and 13 with ROSC. So pretty good data to show that doing something different is working, and specifically the Handtevy and early epi. So let's get to know the app a little bit. These are pictures of the North Fork fire instance because I have this one on my phone, but there can be pictures of just about any of them. So the first screen that you come to, if you have multiple agencies, you come to a screen that looks like multiple agencies. But if you come to a screen that looks like add patient, that's this first one here. You'll always see this one. And then you scroll through to find the size. You can see that the colors align with all the length-based tapes. That's kind of the industry standard now. So all those colors are going to be the same, broke down by age. I'm going to refer to this thing up here in the corner as the hamburger icon as we go throughout today. The hamburger icon, because it looks like 2 pieces of bun and meat in the middle. I don't eat any of the other things on it except maybe cheese. So that's a perfect hamburger for me. So that's what I'll call it. And I don't know a better term for it. If someone does, let me know. When you click on that, you'll see there's some other stuff over here for patients. This will take you back to this main screen here so you can see if you have multiple ones. Charts are archived, training videos, additional materials. And we'll click through some of those. So the additional materials, if you look at the additional materials, there's this document here, the GCS burn APGAR. We also, for our Utah agencies, added the burn resuscitation guidelines to University of Utah to the backside of this, as well as you can add a PDF of your agency protocols if you'd like. So the protocols and all the med dosing and everything is in one space. Like I said here, if it looks like you have multiple agencies that you belong to, you can see and you can add them. And so, you know, if you work full-time for one, part-time for another, you'll be able to have all the agencies because it is, the customization is critical when making the math decisions. Okay, so I'm gonna walk through one really fast. You guys are welcome to follow along. We're gonna do some practices here in a minute, but I'm just gonna kind of click through. So first thing to do is click on add a patient. You can scroll down and I think we're going to do a 6-year-old. So if you click on the 6-year-old, the next thing you're going to see is a screen that gives you a bunch of meds listed. From here, you can scroll up to find all of the meds. When this is customized to your agency, the only medications you'll see on this list are the medications that you carry. So if it's one that might be in the algorithm, like that might be like on the Broslo tape or length-based tape, something like that, but it's not something in your drug box, you won't even see it. So you don't even have to worry about it being in your way. That's the medications. The next tab is going to be drips. If you click on drips, it'll show you all the different drips that you have from you know, push dose epi, if you carry pre-mixed lidocaine, if you're going to make mag sulfate drips, it tells you how to make them as well as what the rates are. Next one will be equipment. This is equipment and sizes based on this kid. So if you scroll through here, you'll be able to see all the different, you know, nasal cannula and a breather mask, BVM, you know, ET tube size. You scroll up, it gives you supraglottic sizes, gives you IV catheter sizes, all those types of things. Then the next one is electrical. So what your shock joules should be. This is customizable by your agency. There are some defaults based on the current ECC guidelines for pediatric resuscitation. So based on if you have a LifePak 15, as well X series, a LifePak 12, whatever it is, they can put that in here as well as change these. You know, there are some agencies who are really progressive, and so their defibrillation, they do the top shock the whole time, and so it would list those same joules all the way through. If you're an agency that scrolls with your, you know, that gets, you know, more intense each time, that's what you see here for both defib and cardio version. And then lastly is the vital signs card. One of the things we published for years in EMSC are the vital signs cards because they're so helpful, because they're, you know, there's so many ranges for all of them. This gives you the vital signs for each of these ages included in here as well. And so helps with that, that need of having those vital signs in a card readily available. So we're going to just go back to the meds now, as if you were clicking on that. And then we're going to just walk through a simulated patient here. And our first patient that we're going to walk through is anaphylaxis. So if this 6-year-old, 22 kilograms anaphylaxis, we click on the epi 1 to 1000 from the previous screen, this is what we're going to look like. So a few things that we can do here. Now, some of the naysayers of the app are saying that you need to be able to still know what you're doing. And this is taking all of the knowledge out and replacing it with an app. That's not true at all, because there's a few things that come into play. Number one, you have a 6-year-old kid who's in anaphylaxis because they ate something they're allergic to, and they have airway constriction, and they have all these things. You have to know as a provider, number one, that they need epi. And then you have to be able to come in here and find it. All we're going to do now is just eliminate the math. You still have to know how to do it. You should still check to make sure it's right, but we're just going to take away the math for you. So epi comes pretty standard, 1 milligram and 1 ml. The dose for this kid would be 0.22 milligrams, which is hard to put that in a mil perspective. So let's go 0.2. You can't really give 0.22 mLs, but you could definitely give 0.2. So you draw this up in 1 cc syringe to 0.2. You give that IM to the kid. You give that IM, you say given. It records it, turns it green, and says, hey, you gave this medication. Then in order to stop that histamine response, we are going to need to start an IV. So we do that. So we come down here, we can either start an IV or we can drill an IO, depending on what we want to do. So you click on whatever one it is. We're going to say an IV. It's going to be, and this size is what they suggest, which I know is always going to be bigger than what you think, but we should right size IV catheters so that the patients get the right amount of fluid. So just because someone's 6 and they're small doesn't mean they're 24 or 22, right? And so we say successful on our 18. I'm just kidding, a 20 on this 6-year-old, then we keep going. So now we're going to come back here. We started that, got our IV started. Now let's give some Benadryl to this kid. So we click diphenhydramine or Benadryl. We can say that we know that this is carried 50 in 1, that the dose is 1 milligram per kilogram. So our total is going to be 22 milligrams. So now we can either give us IV, IM, or IO. So we say IV, 0.4 mLs, and then we say given. That's going to record that for us. So we gave the kid their epi, we started an IV, gave him some Benadryl. The next thing we can do is we want to monitor their end-tidal CO2 as we go. So we can scroll and find that. We can put them on non-rebreather mask or nasal cannula. We can click through all those equipments. For this one, we're going to do ET CO2, click on it. It's going to give us this inline filter. We say successful, records it. Now we go to the, let me back up a couple screens here. So this little icon right here, I'm going to draw on it really fast. Maybe I'm going to, bam. This one I call it the paper airplane because that's what it looks like. That's what you're going to click next. And then it's going to take you to this screen, which is a review and submit chart. So here's my name. I can scroll through here to see the things I did. So if I scroll up, it says that I gave epi, I gave it at this time. I gave diphenhydramine at this time. You can see when I do my best work, it's at 9 o'clock at night, in case you're wondering. So, and then, because that's when my twins are asleep. It's the best time to do work, right, Tia? You know. And then we have, you can see that we started an IV, we did nasal cannula. So we go back to this, everything looks right to me, so I'm going to submit it. You can edit it from that screen if you want to, but I'm going to show you in a second how to do that. So it takes you back to the screen. Once you submit it, you end that call. Now all you do is you log into, if you're an agency that uses Imatren Elite, if you're an ESO agency, there's an integration for ESO as well, but certainly one for Imagetrend. And since that's our state system, that's what we're going to demo for you right now. And that's also the one that I know how to use. So that makes it easier. So you click on this, log in. This is what Elite Field looks like. Click add new incident. Pops up like this. You click on patient info, provider actions. Once you click on provider actions, it pops up and looks like this. It says import from Handtevy here at the top. This is how slick it is. You click on that import from Handtevy. It's going to open it up and say that Brett Cross on 13848. There's no patient identifiable information, so you don't have to worry about this being HIPAA compliant, going to someone else's cloud. There's nothing that ties this patient other than their age and time, which we know can't actually get back to an individual. And so it was me that submitted it. If you use this in like a, if you put this on ambulance 31 or rescue 4 or whatever it is, that can also be listed there. But you know about the time, you know who did it. So you push this little download button. It's going to take a second, and then it's going to download and give you the timeline of all the things. So you just close out the timeline. Then in the provider actions, it's going to be able to give us all the options here that we have to finish. So when we open this up, like we open this epi up, it said that we want to fill out the crew member. We'll want to say if they're improved, changed, worse, or what the complications were. So once we do that, we left everything else in here. It returned it to the same. Now we press OK. That's validated. So the time we gave it the medication, if we needed to change something, we certainly could. The IV start, I'm going to show you that in a second, but if you click on the IV start, it does not actually give a size. So, that's how it said 18 to 20. You'd have to fill in the size of the equipment and things like that with all of these, but at least it gets you the time, and the procedure gives you a little mental reminder to go in and fill those out.
Hey, Brett, we have a question in the chat box.
Yeah.
Wondering if this replaces the paper and note-taking process during transport, or is it in addition to the paperwork and note taking?
I think that's definitely up to your agency, what you decide, but in my opinion, this could replace it. I don't know why else you would need to take paper notes if, I mean, other than like getting demographic information of the patient, but I know a number of agencies that just, you know, have tablets or iPads or something that they enter information directly into image trend with that elite field, or so it'll definitely be up to your agency and how it works. But most people are carrying smartphones these days. Like I said, the only thing about the app is you can't put any patient identifiable information. There's just nowhere to put it, and so it might be a hybrid, but hopefully it could eliminate some of your paperwork. So I want you to walk through this next one with me. So if you will open your app. The other thing about the app that I will tell you is that when it's open and on and your screen is active, it won't shut off. So in training and stuff, you might want to remember that. On a real call, that's probably really handy, that it's not going to silence, so you don't have to try to either use your face, which you can't do with the mask anymore, enter your passcode and all that stuff. And so so it'll just stay open and stay active the whole time that it's on. Just keep that in mind for battery. So for this kid, you start out at add new patient.
Hey, Brett.
Yeah.
Quick follow-up question. They're asking, can more than one person import into the same image trend report if they used it more than one phone on the scene?
Good question. The answer is yes, because we tried it. But let me tell you what happens though. So if you are, there's a few things that I think will come into play there. Number one is that if one person is documenting one thing that they're doing and someone else is documenting something else that they're doing, the two will marry just fine. But if you're both recording things, it might duplicate information that comes in, which again is okay. You'll just have to delete one of them. So, you know, if you gave this last patient the anaphylaxis epi, you both recorded it and you both submitted it, it's gonna say it was given twice. You can always delete it out once you get into the patient care report, because you know you didn't do it twice, but yes, you can do two is the answer, but you just run into some errors. The other thing is another trick that we learned early on in using this was our monitors also submit all of our vital signs. So so when we import from LifePak or Zoll into the PCR as well, if we shock the patient and we put it in the app, the monitor is also going to report that information. And so shocks are recorded twice and those types of things. So we early on made it a rule in our group that we use the electrical component for reference, and we don't actually use it in the app, and we let the monitor transmit all of that stuff over. So so we can still use it for, you know, so we know what the Joule stack should be, but we don't actually say successful or delivered or anything like that in Handtevy. We just let that come over on the monitor later. So good question for sure.
We do still have a few people that are having trouble loading. Rebecca and Justin, if you can look at those on the list.
Let's see.
Justin Larson and Rebecca, I don't have a last name.
Yeah. I didn't see either of you on the list. That's why I'm struggling here, Rebecca and Justin. I didn't see either one of your names.
Effington.
I don't
try to erase the app and then bring it down from your cloud and see if you can.
Yeah. Delete the app and see if that'll do it. That's a good suggestion to you, because I'm sorry. I don't really know a fix after that. Okay, so we're going to start with a 2-year-old for everyone to practice along with here. So we click the 2-year-old. Yeah, I'm going to show you how to delete that. Sherry, that's a good question. I'll show you how to delete that when we get there. So the 2-year-old here is going to be in cardiac arrest. So at the first thing we're going to do is once we start CPR, up in the corner, we're going to click that green start CPR. Hopefully everyone's on mute because it's going to start making a lot of noise. So the metronome's going to go. The metronome's going to help you keep this 15 and 2. Once you get to 15, it's going to then say ventilate, ventilate. It's also going to kick the light on your phone so that it gives you like the visual reminder to ventilate. And then several things are going to happen with this. Once you get to here, you're able to then do that until you get advanced airway, then you switch to continuous. We know that most of our cardiac arrests are all going to be given epi. Some of them may be given some of the others, but and so we're going to go down. First thing we're going to do is drill an IO. So we click on the easy IO. We can just say it was successful. Then we go back to our medications because we know that the next thing we're going to do is give epi. So we either click the epi up here, or you can click it down in the meds. You can scroll through. It's going to tell us that this 2-year-old kid gets 1.2 mLs of the 1 to 10,000. So we give 1.2 mLs. We say given. It's going to turn that green. Now, this is also going to start a timer, and this timer is going to start changing colors when they get closer to needing to give this person epi. So it's going to go yellow, and it's like, hey, it's time for this next dose of epi, kind of as a visual cue for you. So we gave this kid some epi. We waited our 2 minutes of our high performance CPR. So we did a pulse check. In the meantime, we're also going to work on an airway. I think we're going to place, we're going to intubate this kid. 4.5 uncuffed or 4.0 cuffed. We can have this is a really short debate. If you want to have a long debate later, in the pre-hospital setting, we should be using nothing but cuff tubes because things go down, not just air, like in the OR when you haven't eaten for 12 hours. So cuff tubes. So we did that. Then we can switch to continuous over here. Now what it's going to do is it's going to give us a ventilation rate. This is still 1 breath every 10. So it's 10 breaths per minute. In the administrator portal of this, so agencies will be able to set this themselves. So I know there's some controversy around the new PALS 30 breaths per minute versus whatever. So if you're somebody that's like, you know what, we'll meet in the middle. I think it needs to be more than 10, but I don't think it needs to be 30. You can set this to 15 times per minute. And then when you switch to continuous, it will give you the number of seconds between those breaths. So you can adjust that. The other thing you can do is adjust the metronome between 100 and 120. So if you, if you're somebody that wants to do the 120, because that's the research paper you read and you like that, then you can set this metronome up. Totally customizable to your agency with the administrator within your department can do that. So then we decided to defibrillate our patient. So we pushed the defibrillation. This is gonna be their first shock. So we can say shock delivered. And then we get back to doing CPR. This reset button will let you reset it so you can start over that 2-minute cycle basically. So after a couple of minutes here, we decided that because we shocked, we can give amiodarone. So we click on the amiodarone here. The other thing you'll see, this is black. I chose black. I don't know. You can choose the other colors. You can make this red, green, blue with your customization, whatever you want it to be. But the cardiac arrest meds are all on black. So you click amiodarone because you have no pulse. This is, again, going to be 1.2 mLs. And we would know that, too, from our system 1. If we know that the ml dose of amiodarone, because it's always carried 50 in 1, is the same, or 50 per ml, I should say, not 50 in 1, but 50 per ml. And then it's the same volume that you give cardiac arrest. So a little trick for you, but 1.2 mLs, and if you're somebody that wants to check this, because you want to make sure that you're right, you can say the dose of this is 5 milligrams per kilogram. I agree to that. The amount then would be 60 milligrams in this concentration of 50. That's 1.2 ml. So you can work backwards in your head so that you can make sure that if you don't just quite trust just giving the volume, work it backwards really fast, and you'll be surprised at every time it's right. Okay, so we gave our amiodarone. Then it's time for us to give another dose of epi. So click on epi 1 to 10. Now, if you'll notice, when you clicked on it down here at the bottom where it says history of patient, it said that we gave this at 9:19. So we can either 1, know that we already gave it, or 2, that's okay. It's just recording it because we know that they're going to get a second round of epi anyway. So we gave our second round of epi. To stop all your metronomes from going, we can say that we can push the stop CPR icon up in the corner. Because of that second round of epi, you guys got ROSC in the field, so press OK. And then I skipped a slide here, but we'll talk about this one in a second. So now that should hopefully stop your metronome. But now your kid is, they are hypotensive after, so you're gonna do push dose pressor. So you would click on the drips across the bottom. and do epinephrine push pressor. I skipped that one when I added this, so I apologize for that. So click that, drips, epi push pressor, then click on it. This is something that is in the statewide guidelines for AEMTs can do push dose pressors for post-arrest only, and paramedics can do it for other hypotensions as well. So we look at this and we see how we're going to make it. So we start with an epi 1 to 10. We discard 9 mLs. We can then refill the Bristow jet with 9 mLs. That is one way I changed this after I read that because I didn't like it. I'm a fan of just pushing one out of a flush and drawing one up from the Bristow jet. Then it seems like there's less fluid moving. But either way is fine. But really what we're trying to make is epi 1 to 100. That's going to make it 10 mics per ml. So if we look at our concentration, we know it's 10 mics per ml because we did the whole convert it to 10 cc's. And our range is 5 to 20. So we're going to bump this 1 ml at a time. That's 10. That's right in the range. And then, you can say 1 ml given. But let's say you have a protocol that's different than that. Your protocol says 20, or you're supposed to go hard the first one and back off or something later. You're going to be able to change that later too. So we just say given. So within our drips, sour push pressor, it's now green. So we saved this 2-year-old's life. We've given them all the things that they need. And so now we're ready to review it. If you'll notice when we go to review it, it says add patient response to electrical treatment. So again, if you're going to use this for your agency, cool. If you're just going to use a monitor, that's fine too. But you would need to scroll down, find this, click on it, add that they either they converted or they didn't convert, and then come back up here and submit it. And then it's going to go back to, it's going to go to the cloud. The demo one goes nowhere. So if you don't want to do that, you can push the hamburger icon and push delete it, and it'll go away.
Brett, we have a question.
Yeah.
Will it keep using your battery until you submit to ImageTrend? Can you close the app and reopen it and still work on the same patient?
So the answer is yes to all of this. So it won't, like, you can close it out. That's fine without submitting it because you don't need internet to do it. When you, like, if you right now, if you open a patient, put a bunch of information in, and then killed the app, when you open it back up, you should see that patient and all of the information should still be listed there because it's actually stored in the app until it's submitted. And then, so you don't need internet to run it, which is a really good feature too. Everything is stored locally on the app. The only time you need internet is when you are transmitting so that it goes to the Handtevy cloud so you can pull it into ImageTrend. Did that answer the question? Okay. Because Tia, as affectionately coined, if we learn how to treat kids really well, then we'll know how to treat adults versus vice versa. So this is not just another pediatric tool to put on your shelf. It also works for adults too. So we're going to run through one adult scenario here with everyone so you can see how it's beneficial on every call. So we're back at the screen where it says add a new patient. We scroll down, we can see 75 and 100 kilogram adult. I don't know what the logic behind that is, other than maybe female 75, males 100, more average weights, but there are some that are either, so pick one. Most of the meds though are going to be identical for both the adults, just because it's the standard adult dose. So we say 100 kilogram adult, and then because this is a trauma, we're going to say that we first need to we're going to give some ketamine, and we're going to give that IV. And because I'm not starting with the equipment going to the IV, because I'm just going to show you that you can kind of jump into the middle, right? So all trauma patients, even an adult, you're going to start an IV, you're going to give them meds. So you started your IV, you didn't record it here, which is totally fine. So you clicked on ketamine, and the ketamine told you that this is your dose range, 0.1 to 0.3. The dose is 0.3 milligrams per kilogram, amount 30. And so this is the statewide guidelines. Some say 20, some say 30. It just depends on your agency. That's another customizable thing. So we know that for our ketamine, because it's carried 50 in 1, hopefully most of you are not carrying 50 in 1 for pain. You're carrying the 220 because there's more fluid. But if you are, it's totally fine. That would be 0.6 mLs. And then, so we say given. Then it seems like every patient that gets narcotics in our ambulances, when we look at data reports, always get Zofran. It's just a freebie. I want to be the guy. This is how I'm going to retire from the Bureau of EMS, just so you guys all know, and get rich, which isn't going to happen either. But I'm going to invent a fentanyl Zofran mix. So it's one shot of 50 of Fent and 4 of Zofran. And I'm going to require every ambulance to have 4, and I'm going to charge $500 for it. Nobody's think that's funny but me. It's fine. Not gonna get rich that way either. So we did a Zofran. I guess we're gonna do TXA first, but because I don't know where I am with my PowerPoint slides here. TXA. If you're gonna carry TXA, you can carry it. It says right here, given within less than 3 hours, but this is and then from injury, push over 10 minutes to avoid hypotension. Again, I also changed this so that our agencies don't have to use the greater than or less than. It'll say more than, less than 3 hours. So this says less than 3 hours from injury. No confusion with symbols or anything that way. And then the dose, how you're going to give it over 10 minutes. There are some agencies that have their protocol that they drip it in. You can put it as a drip. I just say give it over 10 minutes. You can throw that in a bag if you want, and you can throw it in a liter bag, you can throw it in a 100 bag, you can throw whatever you want, whatever your agency decides to do. So we gave this guy some TXA. I think we're gonna give him some Zofran next. Yep, Zofran was next. Okay. I knew my Zofran was in there somewhere. So we gave Zofran to, you guys can give some ondansetron or Zofran. So now this is the one I'm talking about next time. So the first time we gave ketamine, we decided that we were going to fully do the 30 milligrams, but now we just kind of want to bump it just to keep them happy. And so I'm only going to give 10, but you can't really change that here. Totally fine. So we just say we gave this. This is just going to record that we gave it. Then when we come back and we start this, we're going to start a bolus. Gives you what the dose is. An adult's going to be a liter bolus, but just something to record. We can say that all of our information was correct. And then I'm going to show you in an image trend then that you would just change what they were. So I'm going to actually exit out of here and try to do this in a little more real time. If you can all see my screen then. So we got 2 patients here. I'm using Juab counties for this one because it's the one I got open, and that's the image trend I'm logged into here. So if we decide that we are going to launch this, we get into our app, we're gonna add a new patient. We've been dispatched to a call, and we're going to an 8-year-old in seizure. And so we scroll through here until we find 8. We click on it. Now there's a few things we can do as we're going. Now we can review some of the stuff. If a kid is, oops, I clicked the wrong thing. If a kid is 8 and they're in seizure, I'm probably going to give them some Versed. So I can scroll down until I find my Versed or midazolam. And my first one, I'm probably going to give IM, especially if they're in seizure still, or IN. So I noticed that I have all 3 listed there, so I can do IM, IN, or IV in seizure, probably IN or IM. And so I'm going to say I'm going to do that IN, so I'll just review it, make sure that I'm right. Probably make sure I look at some equipment sizes on my way there, if I'm not driving, obviously, so that I can get a good idea just in case the kid is in respiratory failure or needs something else. And then
Right, is this where you would use the requested feature that you
yeah, you totally can use the request feature. That's a good call. So I was going to do next. So the other thing you can do is as you're going and you're reviewing, to be able to make it pop for you, you can click this and say requested. Now it's going to turn it yellow. It doesn't record it or anything. It just turns it yellow. So then when you get on scene, and it is a kid in seizure, you find your yellow marks, you can go there. And then once you click on it again, then I'll say it was requested this time, and then you can just say given once you do it. So we reviewed some of our stuff here, and then now we're going to get on scene. We have our patient, and our kid is in seizure. So we scrolled down, we found out, we remembered that we were given 5 milligram or 0.5 mLs because we're going to give that 2.5 for this 8-year-old. And so we just say, gave that IN. And then that seemed to help stop their seizure. So now we're going to start looking for some reasons why they might have seized while someone else is starting an IV. So we would come over here to equipment. We can say that someone's going to start an IV. They're pretty postictal, still unresponsive. And then we looked at their vitals. We saw that they were a little tachycardic on the monitor at like 120. Their respirations were like 6. So we know that they're it's probably a little low, and their blood pressure is maybe a little elevated, but it's fine. So we used the vital sign card to see what we were doing. And then we come back, and then one of our crew members takes a blood sugar, find out that their blood sugar says LO on the glucometer. So the next thing that we're going to give this kid is what? Some sugar, hopefully. So we'll find some dextrose. So a couple things that are on here. So we in JUAB, we have gotten rid of D50. So we don't carry AMSA D50 anymore. We just carry bags of D10. So we can say D10 here. If you're an agency that carries D50, you can still have D50 listed on there. I'm happy to soapbox to you at some point on why you should get rid of D50 and just go to D10 bags if you ever want that soapbox, not necessarily for right now. So find the D10. We can say that we gave it IV or IO, depending on how we got it, but it's going to be 12.5 or 125 mLs. So we know we're going to give them about half the bag. And this is titrated to effect too at the D10. So we say given. The kid starts coming around, wakes up. We did a good job. We're going to send it. So I'm going to see that all of my information is right. I looked down here. The question came up earlier, like it said it wouldn't let me delete the end title CO2. So you can click on any of these now, and this is where you could remove it. So if you wanted to delete the IV out of here, you could delete it from here. Just remove it, and then it's gone. If you wanted to update it here, you could update it. I don't actually know if it, we're going to find out together. Okay. So I reviewed it. All my things are good. I changed it to 20. I push send. Now I come over here to image trend. I push new incident. It's going to load up for me. It's going to load up for all of us. AB. So maybe this is a good thing why the PowerPoint was working for me. That's it. Here we go. I was like, I promise it worked. I did it right before we got on here. So come down here, provider actions, import from Handtevy. Here's my 8-year-old I just did. Goes out to Handtevy Cloud, finds it. See how fast that was too. It's actually pretty quick. It's going to import it fairly quickly. Gives you a timeline, close out of it. And then, so it gave our glucose, gave the Versed. So it's IV start. When we come in here, yeah, I didn't do it. So if I do me, and it was successful, it was a 20. Sure. Yep. Once. None. Filled the validation rules out. Now that's done. And then glucose, I can come in and fill this out too to finish it out. And then that's it for the provider actions. So we're almost out of time, but I just wanted to see if there's any questions. Any questions? I won't put my PowerPoint back up because we can.
Feel free to unmute yourself and ask questions or put them in the chat. Just a note that I have asked for email addresses in the chat if you want certification of this presentation for today. Any questions for Brett?
Hope it's helpful for you to follow along too and see.
Yes, I have a question.
Yeah.
My unit is only an EMR level, so
Sure.
is this tool useful for us as well? We really can't do too much.
Yeah, so two things. Yes, it is. It does a couple things for you from a medication perspective. If you maybe not like I said, from the meds, maybe not, but from the equipment sizes, from the you know, the what's the other tabs? The vital signs card, recording some of that stuff. You can definitely be tailored to your EMR level for sure.
Okay, good. Thank you.
Mm-hmm. Any other questions? You can, the demo code, that's a hard one to do because we only have 75 users in the demo code. And so we have to like clear out people occasionally. It'll be open, I will say, for at least the next couple of weeks. I don't think we have anything scheduled course-wise. So we'll say a couple of weeks. And then hopefully by then we'll have some more, a definitive timeline on when your agencies might be getting it.
Brett, can you talk about how the purchase is going to happen and what are the steps that happen to get it to their hands?
Yeah, so I think I just saw today, Brianne can probably chime in too on some of this, but I think I saw today that Primary signed the contract, amending it to allow us to purchase it. And so that just has to make its way through our final purchasing process. And then I think after that, it's just open. And then once that happens, whatever Intermountain's purchase order process looks like, and then all the agencies that have signed up will be then contacted to start their customization from the Handtevy team. And this might be a good plug then if your agency, or you know of your agency, this was really good for providers on how it works, but if you're an agency leader and you haven't signed up for that, reference emails from Brianne, we could probably put the links maybe to the PEP or to the PEC and things for those agencies, but we sent them out several times. So hopefully you have them. If not, let Brianne know and she can definitely get you on the list.
Yeah, if you have not already completed the Handtevy form, it's a Google form, pretty quick to fill out. If you have that in your email, please respond to that. If you have not, please email me and let me know, and I can get that form over to you, and that will start the process.
And basically, guys, the state has a version that is based on the Utah protocol guidelines. And then that version is available. Then they will take that version and customize it to your own agency. But we do have a few things that we need to discuss with your agency leadership before we customize. And so that's why we need you to get in touch with Brianne. We have sent letters out since November, actually since September. And we've had about 50% of our Utah agencies respond. So there's quite a few out there that still need to know that this is a gift. And it really is not going to cost individual providers anything. Any other questions? There's a question here I saw. Brett, how does the request button function exactly besides highlighting the item yellow? Does it send a request to medical control?
Good question, and no. So it just turns it yellow. It actually doesn't even transmit it. So when you go to submit it, if you requested it and didn't use it, it doesn't transmit it either. It just turns it yellow. Theoretically, there's a hospital version of this as well, which is what that requested is originally built for, so that if a doctor did order it, it could just say requested, turned it yellow, so that someone eventually would turn it green that it was ordered. But we have found good utility in the pre-arrival use of it for sure. But no, it doesn't talk to medical control, nor does it transmit to the hospitals. That's something that Tia and I had a pipe dream of asking Handtevy for, is like, when you do submit it, can you submit it to Primary Children's so that they could have it? But unfortunately, we were told no for now.
Now, once again, our newsletter this morning, the one that we sent out, EMSC Connects, has all things Handtevy. Talks about the app, talks about why we've bought it, talks about how your agency gets it, gives you some links to the demos. It's just a super helpful tool. This is something that's going to streamline your pediatric and adult care. And If you use it and use it a lot, EMSC is going to collect data. And if we really see change in the way that we're taking care of kids, we're going to help subsidize you to continue keeping this app beyond our year one. So we really, really want to give this a hard try, and we really want you guys to use it. So if you don't seem to have access or you don't know your user code, you go and shake the trees in your agency, talk to the administrators, and if they don't know about it, have them contact Brianne Glenn at utah.gov. Those of you who were not able to sign on, stick around for a minute and we'll give your names directly to Brett and he can troubleshoot and maybe add you manually. I'm volunteering you for that, Brett. But we are finished. We're at 3 o'clock right now, so we are finished with PETOS. I'm going to stop the recording. And